Hello friends, I am Dr. Samin Afzal Junejo from Afzal Eye Clinic, Hyderabad, Sindh, Pakistan. Today I will show you the phacoemulsification I performed yesterday on a lady aging 55 plus with known diabetes mellitus. The pupil was not fully dilated as a part of preoperative preparation prior to the phacoemulsification, and in this case when I am using the needle cystotome, you can see that the pupil is further constricting, becoming smaller and smaller, maybe due to the release of prostaglandins E2 from iris stroma, and the pupil did not respond to the mydriatics before surgery. It might be due to because of posterior iris adhesions and the loss of tone of the pupillary sphincter muscles of the iris, which usually happens in diabetes mellitus. Now you can see that the pupil is becoming further smaller and smaller. This might be due to the immense release of prostaglandins E2 from iris stroma. And now I am injecting some viscoelastic solution to build up a pressure inside the eye to facilitate the full thickness corneal incision by means of a diamond keratome. This I gave two-step corneal incision, first in the substance of the corneal stroma and then I pierced into the anterior chamber. Pupil is small, you can see it's very clear, and now I will make two side ports, one at 8 o'clock and the other at 3 o'clock position. Side ports on the opposite sides are most important in order to facilitate the aspiration of the cortical matter from 6 o'clock and 8 o'clock position, and also to negate the astigmatism against the rule in aging patients when the plus sign of cylinder is at 180 degrees. Pupil is small, and through the small pupil I will try to do the hydrodissection underneath the rim of the anterior capsule, which is exactly behind the iris sphincter. Now as I am doing the hydrodissection, pupil is further constricting. This is due to the manipulation of the iris and the release of prostaglandins E2 from the iris stroma. Prostaglandins E2 are responsible for the initiation of the inflammatory process, capillary dilatation, and the release of proteins from inside the vessels into the extracellular compartment. I have tried to do the hydrodissection and a bit delineation because I am facing difficulty due to the smaller size of the pupil. It is not very much dilated widely, and now again I will inject some OVD dispersive to create a pressure inside and facilitate the phacoemulsification process. Now here I will try my level best to have my approach through the equator, which is very successful in small pupils. You will see that after cleaning the surface, after removing the cortical matter from the surface of the nucleus, I will create a small depression in the middle of the nucleus, pull it down and catch hold of the equator, and now the equator of the nucleus is very much in positive contact with the phaco tip. This is the equator of the nucleus which I am playing with. I am giving tiny bites at the different sides of the equator and will try to break the nucleus, keeping my phaco tip exactly in the middle of the pupil. And at the same time I am also using my side chopper to break the nucleus into small pieces. After breaking the nucleus into small pieces, I will take up the small pieces one by one and apply a phaco of not more than 40% with the flow rate of 38 and vacuum of 550. During the whole procedure, I will keep my phaco tip exactly in the middle of the pupil in order to save the pupillary rim to be caught during the phacoemulsification. And now I will try to catch hold of the epinucleus. That's done. Still the pupil is small. In presence of a small pupil, I will inject OVD dispersive before going for the irrigation and aspiration step. If the pupil is smaller, nothing is to be worried about. We should be very patient and cautious regarding the removal of the nucleus and the aspiration of the cortical matter. Now, by means of a side port, I am dislodging the epinucleus and taking it up by the help of Simcoe cannula and completing the aspiration process. We should not dip the cannula deeper into the substance of the bag in order to avoid posterior capsular rent. The cannula should be very superficially placed in the middle of the nucleus, and under full irrigation we should try to aspirate the cortical matter. After completing the aspiration, I will inject the OVD dispersive to provide a best possible room and lubrication for the intraocular lens to be implanted. In diabetics, we should avoid using the rigid lenses or the silicone material lenses. Acrylic material is most acceptable, does not result into any postoperative cellular reaction or the anterior or intermediate uveitis, and result into best postoperative visual acuity. A foldable hydrophilic one-piece intraocular lens is being placed exactly into the bag. And now, as a last step, I will try to irrigate the anterior chamber and also behind the optical zone of the intraocular lens to remove the viscoelastic solution so that there should be no more transient rise of intraocular pressure after the surgery on the first postoperative day. And also I wish to avoid the postoperative cellular reaction, which usually happens when there is a small amount of viscoelastic solution left behind the nucleus of the IOL, most particularly in diabetics. Stromal hydration is being performed. Intracameral injection is given, consisting of steroid, antibiotic, moxifloxacin and the pilocarpine. Pupil is becoming smaller and smaller and providing best support to the newly implanted intraocular lens to keep it into the bag. Thank you very much for your patience. Dear colleagues, if you like my video, I will request you to please subscribe and like this channel. Thank you very much.